Presenting this episode of Doc Talk with Dr. Bond is guest host attorney Van Vu.
Hello, my name is Van Vu, and today's topic is states with legal limitations on access to hydroxychloroquine and chloroquine. This is part 2 of a 2-part series. And if you remember from part 1, we talked about the availability of these 2 particular drugs in the marketplace and at what point they went on the shortage list and whether or not we currently have a shortage of these drugs. We also looked at whether or not there were enough of these drugs in circulation in order to be able to provide them to the general public in various settings, including the hospital and outpatient settings. In this particular podcast and video, part 2, we're going to be talking more about the legal side of the house, whether or not there are any restrictions that have been placed on the prescribing and dispensing of these particular drugs. And in doing so, we're going to be looking at all 50 states. So what I did here was I did a survey of all 50 states to see whether or not there had been any sort of guidance, laws, regulations, anything like that provides for restrictions in any way on the ability of the doctors and the pharmacists to make these drugs available. So the strategy, if you're listening to this, is to identify the state that you're in and see whether or not there are any legal restrictions in your particular state. And I highlight the word legal because it's very different from states that provide, that are either silent or that provide guidance and advisory opinions. So we're looking specifically at whether or not your state has any kind of law or regulation that has the force and effect of law that really dictates what a person can do within that state. If you have legal restrictions within your state, identify the source of the law. Is it an executive order, for example, or is it more of an emergency regulation? By knowing what the source is, you'll be able to look it up should you need to do so. Also, if you're denied these drugs, either through your doctor or your pharmacist, then by knowing the whether or not there are any legal restrictions in your state and the ability to look that up, you can see in front of you whether or not the denial is really based on the law or the person who's denying it, whether or not it's based on their professional discretion in some way. All right, so why don't we start? I divided this up into 4 main categories. The first one are states that are silent, so namely states that have not said anything at all, one way or the other, about whether or not physicians can prescribe or pharmacists can dispense these particular drugs within the context of this pandemic to treat COVID-19. The second category are the states in which governors have acted. They've enacted some sort of an executive order at the level of the government, the governor of that state. The third category are state board actions. So, of course, we have a system of 3 different arms or branches of government. One is the executive branch. Of course, the other 2 is the legislative and the judiciary. So within the executive branch under the governor, every state has a system of agencies and departments that executes the laws. They carry out the laws and they ensure that the laws are carried out properly through various enforcement actions. So this third category has to do with those boards that are under the governor. And typically you'll see pharmacy boards or a health and human services type of an agency or a medical board or some combination of any of those. And then there's the fourth category. The fourth category has to do with states that provide some sort of position, whether that's advice or guidance related to how these drugs should be prescribed and or dispensed. That is very different than the states in which they have executive orders and emergency regulations, because advice and guidance does not have the force and effect of law. But we'll get into that a little bit more. And then finally, at the very end, we'll discuss, what next, what happens from here. So let's go ahead and move on to the states that are silent. Now, there are 23 states that have not weighed in any sort of way, at least for these 23 states, I have not been able to find any sort of guidance either from the governor's office or from any of the state agencies related to the prescribing or dispensing of hydroxychloroquine and chloroquine. So if you are in one of these states, monitor the changes because things are happening every day. And this information, mind you, is current as of about April 4th. So if there's any changes after that date, then it would not be included within this particular talk. Watch also what other states are doing. Your state may be next because from what I've seen in looking at all 50 states, things change from day to day. I mean, even as late as last Saturday, Saturday, things were changing with regards to a lot of these restrictions and such. So the states that we have that are silent include Alaska, Colorado, Connecticut, Delaware, Washington, D.C., Florida, Georgia, Hawaii, Illinois, Maine, Maryland, Massachusetts, Minnesota, Montana, Nebraska, New Hampshire, New Jersey, North Dakota, Pennsylvania, South Dakota, Virginia, West Virginia, and finally Wisconsin. So as far as I know, all of these states have not weighed in one way or the other regarding whether or not doctors should be bound in some sort of way, limited, or pharmacists limited in terms of dispensing this medication. Moving on to states with executive orders in which the governors have acted. Now, this is executive orders are a power of the governor in a time of emergency. Usually, this is something that can only be done in the state of an emergency. And that's pretty much what both of these orders in the state of New York as well as Oklahoma. There's really only 2 states that have these executive orders. They're based on the emergency powers of the governor. And so it's interesting because I don't think anyone's really considered at this point whether or not by issuing these executive orders, the governor's office actually overstepped, considering the circumstances in which they were issued. Typically, you can find these governor's executive orders on the governor website. So if you want to look it up for New York or Oklahoma, simply go to your state's governor's website, and it's usually posted there under executive orders. New York. Now, New York has had probably the most public PR news coverage regarding this particular executive order. The first one, and it's Executive Order 202.10, was issued on March 23rd, 2020. There has been a revision, and it was a revision about 4 days or so after this. But when it was issued, it was fairly brief. It was contained within a larger executive order, and it states 2 circumstances in which hydroxychloroquine and chloroquine can be dispensed by a pharmacist. Okay. The first circumstance is when it's prescribed consistent with an FDA-approved indication. What we know is that at that point on March 23rd, and even to this day, there has not been an FDA-approved indication for the treatment of COVID-19 for either hydroxychloroquine or chloroquine. And so, number one, bans the dispensing of these particular drugs for the treatment of COVID-19. The second part of this executive order has to do with state-approved clinical trials. And it's interesting that they use the word state-approved, but it also goes on to say that if you're part of this clinical trial, then you have to have been tested positive for COVID-19. And we all know the difficulty that many states are having with regards to the availability of the tests and the timing of getting the results back. It's very specific here, number 3, that no other experimental or prophylactic use shall be permitted, and any permitted prescription is limited to a 14-day prescription with no refills. So clearly here, what the executive order was trying to do was to prevent stockpiling by what they perceived was doctors prescribing these for prevention and prescribing them for friends and family. So here's the rationale. The treatment's not supported by evidence, and they were also concerned about hoarding and shortages of the medications. That becomes important because remember, the rationale needs to be something of a state of emergency that allows for the order itself to be made, because it's an emergency power under a situation in which there is an emergency. Now, 4 days later, on March 27th, 2020, New York revised its executive order. Now, whoever wrote this second executive order was probably a much better lawyer than the first one, because if you noticed from the first one, there wasn't a situation in which hospitals for inpatient were allowed to even use the drugs for their inpatient care. So based on the first executive order, there was no exception or allowance for the use of either of these drugs for people within the hospitals. But let's go ahead and look at this particular executive order. Number one is the same, where pharmacists are prevented from dispensing unless it's for an FDA-approved indication, and we know malaria, lupus, rheumatoid arthritis, all of those are approved. Number two is where there's a huge, I think, opening in order to allow for the prescribing of these drugs to an outpatient in an outpatient setting. And what it states here is that it's for an indication supported by one or more citations included within a compendia specified within federal law. Now, the federal law that's referenced is part of the Social Security Act, and the particular provision has to do with drugs that are prescribed and paid for through public medical assistance programs at the federal level. And so, of course, if the feds are going to use their money, they want to make sure that there's no fraud and that it is prescribed in accordance with good practices. So that's the provision that number two here references. So let's take a closer look at this provision. Now, because treatment of COVID-19 is not an FDA-approved indication, this becomes the fallback provision for allowance of outpatient prescriptions to be filled. So it's for an indication, but it has to be supported by a citation in this particular compendia. When you pull up that federal law, one such compendia is the American Hospital Formulary Service Drug Information. There's that blue dot at the bottom. So within that particular formulary, you can access this online, doctors can, with an account. It lists all of the drugs, and then specifically what the uses of those drugs are, and then it also lists certain analysis regarding whether or not that drug is a good use or is basically effective for a particular use. So if you were to pull up the American Hospital Formulary Service Drug Information and look up hydroxychloroquine and chloroquine, under the uses, of course, you have malaria, rheumatoid arthritis, lupus, but now it also indicates COVID-19 treatment. And within those uses, that analysis does cite to two different sites that offers some support for the use of those drugs for COVID-19. And the citation specifically is to the Chinese protocols that were released by basically their equivalent of RCDC, as well as a reference to RCDC and the reference on the website that lists these drugs as potential treatments for COVID-19. So going back to the provision here, number two, it is an indication that's included within the appropriate compendia, and it does have citations to support the use of those two drugs for the indication of COVID-19 treatment. So arguably, now this revision allows for New York pharmacists to prescribe for COVID-19 treatment because it does include the specific documentation that's required within this executive order. Going on to number three. for patients in the inpatient setting and acute setting. So this is a correction from the first one that allows for, of course, these drugs to be provided to hospital patients, as well as for patients within a skilled nursing facility. We know in states like Washington, there were outbreaks within skilled nursing, and many people within the single nursing facilities passed away once that happened. And then finally, as part of a study approved by an institutional review board. So it's no longer now a requirement that it's a state-approved clinical trial, which in some circles might be a little odd language. The other state with an executive order is Oklahoma. And Oklahoma's executive order is pretty basic. It includes a lot of information that really doesn't do a lot to restrict. Basically says no prescription for either of these drugs may be dispensed. Again, it's targeted at the pharmacist unless all of these things apply. The prescription itself bears a written diagnosis consistent with the evidence. And as we spoke about in the New York situation, the evidence, at least there's citation there to support the use for COVID-19 treatment, as well as supply limited to 14 days because, of course, the concern there is the hoarding and the shortage of the documents for people who were previously established on the medications. A lot of these provisions, they do ban refills, but if you do need to extend the prescription for some reason, it requires a new prescription that satisfies these requirements again. It's interesting because when you look at Oklahoma, because remember the executive orders are done under a state of emergency, this particular order expires in 30 days. So it was from the date of March 21st, which means on April 20th or so. That would be about 30 days, and therefore this executive order within Oklahoma would expire unless another order is issued to extend that. Now, moving on to state board actions. We have a number of states, 7 in fact, that have passed some sort of emergency rule. And this process is where the agency, the state agency, goes through an emergency rule-making process. Typically, when you pass a regulation, it's pretty involved. There has to be notice and comment. It takes literally months to do. But under the emergency rule-making process, that process is usually shortened and it's possible to pass emergency regulations in as short as a few days. But they still usually require notice and comment to the public and from the public before the rule itself is passed. One thing I want to point out is that these emergency rules, usually for them to be justified, they have to state what the emergency is. And so a lot of what we're going to be going through is the rationale. What is the reasoning? What did they use as the emergency in order to pass these particular emergency regulations? And you decide whether or not the situation that they justify as an emergency actually exists or not, having heard part 1 of this podcast, but also whether or not it exists given the changing circumstances from day to day and what we know about COVID and the nature of these medications. So typically, if you're going to be looking for these, they're posted on the agency website. So if they're passed by the pharmacy board, then it would be on the state pharmacy board's website is where you'll find them the easiest. So moving on to the most high probably the most controversial, why don't I say that, emergency regulation is the one coming out of Nevada. Very often in the media, you hear it as an action by the governor, but this, in fact, is an action by the board underneath the governor. Within the state of Nevada, they passed this emergency regulation on the 23rd, so the same day that the New York executive order was issued, and it states that the prescription for chloroquine and hydroxychloroquine may not be filled, again, focusing on the pharmacist, to an outpatient, for COVID-19 diagnosis, period. So if you have this COVID-19 diagnosis, you cannot get this in an outpatient basis. Also, what's interesting about this executive order is that it bans the prescription for these drugs for any new diagnosis. So even if you have a new diagnosis of rheumatoid arthritis or lupus, you can't get this filled on an outpatient because, in fact, it's a new prescription in Nevada. And I think that's pretty harsh. The prescriptions for these two drugs must have been confirmed by written ICD-10 code on the prescription itself from the prescriber, and then they also have to be limited to a duration of 30 days. The reasoning behind this is to prevent hoarding, and then specifically the hoarding was what they believed was hoarding by physicians. The rationale also was for the safety of the public, because the efficacy of using these drugs for COVID-19 had not been established. And also there was a concern about filling prescriptions that were not written for a legitimate medical purpose. And again, this goes to a lot of the PR reports about doctors writing them prophylactically or writing them without a physician-patient relationship. To their family, to themselves, to their coworkers, to their friends, who do not have any sort of FDA-approved indication for those drugs. So that's the reasoning behind this particular emergency regulation. The exclusion for the regulation is inpatient. So inpatient within hospitals, this regulation did allow for hospitals to prescribe these drugs if you are already admitted into the hospital, and for patients who had existing diagnosis for rheumatoid arthritis, lupus, malaria, those types of things prior to March 23rd, 2020. Moving on to North Carolina, this was effective April 1st, so just last week, and it lists chloroquine, hydroxychloroquine, and azithromycin as restricted drugs. And as restricted drugs, it restricted pharmacists again from dispensing unless the prescription itself had a written diagnosis consistent with evidence. A lot of these provisions are using that verbiage, written diagnosis consistent with evidence for its use. So at the time, let's say even a week before that, March 23rd, the FDA hadn't issued its emergency use authorization. A lot of information was still very much new only a week ago. And a lot has changed since then, where now there is the emergency use authorization. Vice President Pence came out and said, yes, you can use this for off-label. There's more studies that have been coming out. There's more data that's coming out. It's now included within that compendia that we talked about, and so forth. And so this reading of this language is now evolving as the days go. It also states that for COVID-19, that the prescriptions, the diagnosis for the COVID-19 has to be included within the prescription itself. And of course, they limit it to 14 days with no refills. It's interesting because this is different, and anything I put in purple is different from a lot of other states where it says that no prescription is allowed for prevention. So if the pharmacist thinks that there's really no indication and there's no diagnosis that's listed on the prescription, then they cannot fill that prescription because if they deem that it's for prevention, which is an improper purpose for that prescription. But they do say that the prescription can be phoned in, even though the regulation itself indicates written diagnosis. So if the prescription is phoned in by a doctor, then the pharmacist has to write it down in his or her notes or documentation for that, and that, in fact, can satisfy the written requirement. And then finally, the exclusions to this is also for inpatient in hospitals, as well as prescriptions previously established. Moving on to Ohio, their emergency rule was established to be effective March 22nd, and then they wound up revising it only a few days later. So as you can see, it's a very dynamic situation. Within Ohio, they state that none of these drugs may be dispensed, again, targeted at the pharmacist, unless the prescription bears a written diagnosis code from the prescriber, so a diagnosis, and they're using probably an ICD-10 billing code. And then they also go on to say that if it's for COVID-19, the diagnosis must be confirmed by a positive test. And so this is a term of art, because confirmed by a positive test actually means that a person was tested at the state level or privately, within the state by a private agency. And if they receive a positive back, they're considered presumed positive. not confirmed positive. So the confirmed positive is when that information is then transmitted to the CDC, and then the CDC confirms that that test is in fact a legitimate confirmation, and then the CDC confirmation becomes the confirmed positive. So this is a really, really restrictive standard coming out of Ohio, and it indicates specifically that no prescription for presumed positive or for prophylactic use. So not for prevention and not for even people who are already tested as positive, within the state, unless it's confirmed positive by the CDC. And like other states, they limit the amount to 14 days with no refills. Some of the reasoning behind it is the shortages of the drugs, and they're trying to preserve it for people with lupus and RA. And finally, looking at Ohio's revision on March 26. The revision basically reversed the requirement for requiring a confirmed positive test because, one, it was overly restrictive and probably not possible in most situations, but it allowed now for the presumptive positive. So if it's tested, a person's tested as positive at the state level by a state or private or entity, then that presumptive positive can form the basis for the COVID-19 diagnosis. However, the presumptive positive is only allowed for situations in which the person is involved in a clinical trial, or if it is for continuation of treatment, say if the person was in the hospital and then discharged and they needed a prescription upon discharge to take these prescriptions moving on. So it would be limited to that situation in which they're discharged from the hospital. In all other situations, the provision would still require the confirmed positive test. Moving on to Oregon. Oregon here also focuses on the dispensing. As you can see, Oregon put a time limit on this emergency regulation, which is not unusual because emergency regulations usually have a finite time period. However, what we're looking at here is, again, they're focusing on the dispensing, and a lot of this language is really not unusual. In the beginning, the prescription is for a continuation of therapy begun prior to March 8th. Why they chose that date, I'm not entirely sure. And also, the prescriber has provided diagnosis code based on clinical findings for which the medication is medically indicated. Okay. If written for COVID-19 diagnosis, the patient is hospitalized with a positive test result for COVID-19 infection. So just to summarize, within Oregon itself, if you had the prescription before March 8th, you're good to go. You can still get it. If you are prescribed this for something that is FDA approved or medically indicated there, then you are good to go. And if it's written specifically for COVID-19 diagnosis, okay, so numbers 1 and 2 don't matter. If you're doing it for COVID-19 treatment, then only 3 matters. So then that means for those patients, they have to be hospitalized. So Oregon does not allow for outpatient prescription of these drugs to be filled. The reasoning that they use is to protect the supply, and also, of course, the safety of hydroxychloroquine and chloroquine is not established. And looking at the date there, this was one of the early ones as well, on March 25th. So with this new revision, the new information that tests are hard to get and slow, they then revised it because, again, a lot of these early regulations that require test positive, they're seeing that people just weren't getting them, and so they had to then pivot. So with the revision on April 2nd, they state that the prescriptions allowed based on clinical diagnosis, but still it's only for inpatient in hospital setting. Again, not for outpatient. You don't require another test positive. It can be based on a doctor's clinical diagnosis from seeing the patient without a test. But again, it can only prescribe for inpatient care, or dispensed rather for inpatient care. Within Rhode Island has an interesting one. There's a couple of things that make it unique here. They indicate that prescribers can only prescribe within the usual scope of their practice. So this is one of those states that we're addressing people like dentists and podiatrists prescribing hydroxychloroquine and chloroquine to themselves, their friends, people they know. That typically aren't the type of provider that prescribes these types of drugs for malaria, lupus, treatment of a disease. Number 2, if prescribing for COVID-19, the prescriber must indicate on the prescription all of the following. We've seen before the diagnosis, and here they reference the ICD-10 code, but here they also require a phone number. So what they're doing there is making it easy for the pharmacist to call them in order to confirm the prescription itself by requiring the phone number of the prescriber. Number 3, if prescribing for COVID-19, the prescriber must document in the patient's medical records. So now they're dictating what you put in a medical record. And the information that is required to be in there for a prescription to be written includes the risks and benefits of treatment that you discussed with the patient, you, the prescriber, and number 2, the clinical rationale for the treatment, and then you also have to indicate what you're citing to. And that has to be at least one peer-reviewed article that justifies the clinical decision. And then, of course, FDA guidance if there is any. So it's a really interesting approach that's, I don't know, in my gut, without looking into it, looks to be quite onerous of a requirement, and interesting that they're getting into the details of what to include within the medical record itself. Now, the exclusion for this particular emergency rule is for doctors licensed in Rhode Island that are board certified in infectious disease and critical care. So if you're one of these 2 disciplines, specialties, then this doesn't apply to you, and that's a little odd. So in Texas and Idaho, what they say is that no prescription for either of these drugs may be dispensed unless there's a written diagnosis, which we've seen before, and the prescription's limited to 14 days, unless previously established before March 19th for, I believe, Idaho, and Texas might have a different date. And then, of course, there's no refills without a new prescription. So Texas and Idaho, they take a pretty standard approach. It's not unreasonable to limit it to 14 days. For treatment of COVID-19, because we know that most of the protocols are up to about 10 days. 14 days is fairly unusual. Now moving on to the last category, and what we're talking about here are states that provide advice and guidance. Advice and guidance typically does not carry the force and effect of law. So law typically is anything that is passed by the legislature, which becomes a statute. Anything that is passed by way of an emergency regulation, which is a delegation of power by the legislature that allows for state executive agencies to pass rules that are more detailed, basically. But when an agency basically says, hey, this is what we think, outside of those formal rulemaking processes, then that's not really anything that carries the force and effect of law. It doesn't have any of the procedural protections. There are 18 states, as well as the Washington, D.C., did provide advice and guidance, regarding this particular issue in form of either prescribing or dispensing hydroxychloroquine and chloroquine. Be real careful, even though they don't have the force and effect of law, states' agencies often do have enforcement mechanisms. So if they are your medical board, they can go after you for your license if you act contrary to the state statutes that govern your practice, for example. So even if these state agencies are merely stating their opinion or their stance on something, that's sort of like a shot across the bow. They're saying, hey, look, this is what we think. If you're going to risk acting differently than what we think, then potentially you could be brought up under one of our enforcement actions for acting unprofessionally or for doing something that's contrary to your professional standards. So, it's more of a warning. It doesn't really have any legal effect, but, from a practitioner's perspective, you just have to be very careful. In Alabama, the concerns that were listed were potential hoarding and then, of course, no research with reliable success. A lot of these were issued fairly early. And in Alabama, they just had a real brief statement that said the Alabama board does not intend to set policy about which drugs you should dispense or about the best decisions for your circumstances. But, they did go on to say, we don't think there's any research for prescribing this. Arizona, their concerns were to prevent shortages and that there wasn't enough clinical evidence. So basically the same things. And they state that pharmacists should use their professional judgment when they evaluate a therapeutic appropriateness when determining whether or not they should dispense what was prescribed. So this is more of a, hey, remember your professionals, do your job. And there are standards in which you have to consider before you dispense. And because this is an ever-changing situation, you really have to balance the equities here and balance the interests. Some of the considerations that they raise in Arizona is the diagnosis consistent with evidence for its use? And as we've seen over the past week alone, this is an ever-shifting position. Is this routine medicine for the patient? So is this something that's consistent with, other medications that they're being prescribed or other diagnoses that they have? And is there a limit on doses? Is the dose that is prescribed appropriate for the particular diagnosis and use and so forth? So I think reasonable considerations that are put out there. So that was helpful guidance to say, hey, look, use your professional judgment. And if you don't know what that means, think about these things. Arkansas, the concern was no clinically proven treatment, not approved for prevention, and to limit potential hoarding. So what they say in Arkansas is if you use hydroxychloroquine and chloroquine, it should be restricted to patients who are admitted to hospitals with COVID-19 infections. And they also, the fact that if you do prescribe this, that prescription regimen and the treatment should be discussed with an infectious disease physician. Why it should be discussed with an infectious disease physician if a competent physician is prescribing it. Not entirely sure why they would require that. But in any event, that's what they're saying is their position, that it should be limited to these people, but they don't say it has to be limited to these people in the inpatient setting. In California, I did this in red. There's a couple of states that took an interesting approach, California and Michigan. And the guidance that they submitted or sent out was more of a veiled threat, in a sense, depending upon how you read it. So what they said within California was, they were concerned about prescribers who are wrongfully hoarding the prescriptions and prescribing it for themselves. That should be a number 2. And so 3 different agencies, the Department of Consumer Affairs that does all the licensing, the Medical Board, and the Pharmacy Board, they did a joint letter, basically, that said, we want to remind healthcare professionals that inappropriately prescribing or dispensing medications constitutes unprofessional conduct in California. So as you can see, that's another situation in which they're saying, hey, look, if you're going to be doing this, given these particular concerns that we've raised in terms of prescribing, hoarding, and not having an appropriate doctor-patient relationship, you could be brought up under our boards for unprofessional conduct, so be forewarned. Moving on to Indiana, Iowa, and Missouri. Now, I actually really like what Indiana, Iowa, and Missouri did. They listed as concerns that prescriptions for prophylaxis, namely prevention without an actual diagnosis, leads to stockpiling perhaps, and that could potentially lead to shortages. So their approach was to put out advice or guidance to both prescribers and pharmacists. And they basically said, hey, look, if you're prescribing for prophylaxis or friends and family coworkers, we really don't recommend that. That's probably not the best thing to do. And they also say, hey, look, we recommend that if you are going to prescribe these, include the diagnosis and limit it to 14 days for COVID-19. So, that's perfectly reasonable that if you're going to be doing it, be very apparent about it, that it's for this particular treatment, and here's the limitation on the amount if you deem that's appropriate. But we think that's a pretty reasonable amount. What they say for pharmacists is, hey, if you get any of these prescriptions, use your professional judgment. Confirm the legitimate medical purpose of these prescriptions. And to do that, look to see whether or not it's for prophylaxis or for a presumptive positive. Is it someone who's been tested already and it's for treatment of COVID-19, or, is it for prevention? So if you decide that someone who's been tested, for example, could use this medication, then perhaps look at the dosage as well to see if it's an appropriate amount before you dispense. So I think that's a reasonable approach where they're focusing on the different angles. One is the prescriber and the other is the dispenser, and they provide reasonable positions and recommendations. They specifically state, particularly in Indiana, this board or the board is not recommending that pharmacists refuse to fill. The board is recommending that pharmacies use caution and must balance the interests and act in good faith. So again, they're saying you're professionals, do your job. Consider what you need to consider and be mindful of this potential shortage and the impact on all people involved. Kansas was passed on the 31st of March, and the concern they list is that the only FDA-approved use is for the emergency use authorization for inpatient in the hospitals. And then they also reference drug shortages that are affecting the prior users, people who were on the prescriptions before all of this happened. So in Kansas, they encourage vigilance in processing new prescriptions, and obviously that is for the pharmacists. They also recommend verifying the diagnosis, so have the pharmacist call the physicians. And regarding inpatient, they're saying to the inpatient, the hospitals, hey, look, if you're going to do this, get your drugs from the Strategic National Stockpile. By doing that, and to serve the inpatient care, there's millions of drugs out there, then perhaps this will ease the shortage that we're seeing, of these drugs in circulation. So that's a very reasonable approach to take as well. They also list considerations, for the pharmacist to look at. Is the diagnosis consistent with evidence for use? Again, that's a ever-evolving, determination now. Is this routine medicine for the patient, and is there a limit on doses that's appropriate? Okay. Kentucky. I love what Kentucky is doing. I think the people, whoever is handling these in Kentucky, are really competent. Coming from a government lawyer here, or a public lawyer. So it's interesting because Kentucky originally released their what they call directives, and directives is actually hey, you need to do this, but it was actually advice or guidance coming out of Kentucky, and it was early on, March 23rd. This is the same day that New York passed its executive order. They list as concerns to prevent hoarding and stockpiling of these two particular drugs as well as azithromycin. So originally, Kentucky's advice was, hey, no dispensing these drugs unless there's a written diagnosis, and let's go ahead and limit it to 10 days, unless it's previously established, for patients for lupus and so forth. And then they also say, let's not do refills unless you need that. But when the circumstances changed, and this is a little bit more than a week later, they made a clarification on the 2nd of April, and they said, hey, these directives do not replace the pharmacist's professional judgment. They're not intended to hinder the appropriate use of these drugs, and the board wants to ensure that all people who need the drugs have access, and they list the people that they're talking about. These are patients who were previously treated with these drugs. It also includes patients with a COVID-19 diagnosis. They don't say a confirmed test or a positive test or a presumed positive. They're saying patients with COVID-19 diagnosis, meaning that includes the clinical diagnosis by doctor as well. They also say this includes persons under investigation for COVID-19, so people who are being treated for it, in which they're still trying to figure out what's going on, as well as post-exposure prophylaxis, PEP, of high-risk individuals. So in Kentucky, they're very mindful that, hey, if you're a frontliner or if you are someone who is constantly out there circulating as an essential person with an essential function, where you're coming into contact with a lot of people and there's a potential for that exposure, then possibly, the prescriptions for prophylaxis might be appropriate. And so they're not limiting it to prevention, limiting it and preventing people to get this for purposes of prevention, at least in the state of Kentucky. So I thought this was a very balanced approach, as well as an approach that you can see was evolving with the times and changed circumstances. They also make very clear that, hey, even though there's a written diagnosis requirement, a verbal authorization is okay. It's okay to prescribe for off-label. It doesn't have to be FDA approved. And, some inappropriate prescribing, are these kind of situations: hoarding, stockpiling, prescriptions for excessive amounts, prescriptions that are for too long of a duration in order to get more pills. Where there's no doctor-patient relationship, where it's not in the area of practice, like dentists and podiatrists prescribing these drugs. So again, very, very reasonable factors that are considered to see whether or not they should be dispensed. It's not a free-for-all. It has to be for a legitimate medical purpose, and these are some considerations. In Louisiana, the concerns, again, it's very typical. Louisiana became a new epicenter. And so originally they were fairly restrictive, and then they revised their provisions to say, hey, now that we have so many more infections, we need to change our original stance. And we also need to conserve the supplies for the next 30 to 60 days because we don't know what's going to happen in Louisiana with all these infections. And I think in terms of all of the concerns, that was probably the best stated concern, as opposed to, hey, we're hearing reports out there of physician hoarding and doing all these things that may or may not have been confirmed. So within Louisiana, they say, hey, let's limit these prescriptions to 14 days for COVID-19. And about 30 days for other people because, we're looking at everyone, not just protecting one particular class. And then also the professional discretion for the prescribers, the prescription in order to release, look at things like high doses. Is there a, illegitimate doctor-patient relationship, and is it for an illegitimate, medical purpose? So they originally issued their emergency rule on 3/22 before New York issued theirs, right after the president tweeted. And so, based on reports of hoarding and shortages, but they ultimately determined that, hey, look, we're going to rescind this because there's no shortage. We confirmed it in Louisiana, there's no shortage. And, and so instead of passing another emergency rule, they said, we don't need an emergency rule. This is a situation where an advice, some sort of guidance is enough. And so they issued this on the 25th, just merely 3 days later, due to the rising infections within Louisiana. Here's Michigan. There's been a lot of PR about the governor of Michigan and the threats. This is what they're talking about. The concerns were that prescriptions were being written by doctors to family and friends. The doctors were stockpiling. The drugs were not proven to treat COVID-19. And so within Michigan, there was a letter that sent out saying, hey, professionals, pharmacists, this is a reminder that you have a legal obligation not to dispense, unless it's a legitimate medical purpose. And if you think that there's no legitimate medical purpose, you should report the prescribers to their appropriate agency. And that, remember, reports of inappropriate prescribing and things that are illegitimate may be investigated and referred for further action. So again, it was one of those, be our eyes and ears, and if anyone's doing this, tell us, and then we'll use our hammer to come down on them. And that did not go over well to the public. What we saw in the news a few days afterwards was a lot of media about the governor reversing, quote unquote, her position, and also a quote from a state senator that said, "Oh, oops, thanks for bringing this to our attention. It was a mistake." But I have not seen any sort of a formal rescission of this letter or otherwise, and so that's what's out there. Mississippi, a couple interesting things about Mississippi is that they're saying, hey, if you're going to use these drugs, it should be restricted to people who are admitted to hospitals. And also, of course, this should be discussed with infectious disease doctor. This was similar to one of the other states. And that this is the difference here, that patients should be monitored when on these drugs due to toxicity concerns. That's something that Dr. Bond actually very much agrees with and has stated often that, in prescribing these, you really have to be monitored because there's so many different factors to come into play. And so he monitors his patients very, very closely, calling them daily and multiple times a day to see how their condition and situation is changing. In New Mexico, nothing really different here. They were advised to prescribe appropriately with good judgment. Prescription should include a diagnosis and, of course, an appropriate doctor-patient relationship. Nothing different. New Mexico also states that, and I found this a little interesting, hey, it's not our intention in New Mexico to initiate any action against pharmacists by the New Mexico board for denying the drugs. So it was worded as for denying these drugs as opposed to for dispensing the drugs under appropriate circumstances. So if you deny them, hey, we're probably not going to go after you if you deny these. Pharmacists must be aware of current indications for them when considering whether or not to dispense. So I did appreciate that statement to give a nod, I guess, to the changing landscape that we're considering. Coming towards the end, we've got Tennessee. Again, pretty much the same bases. And also they want to, say, hey, we want providers and pharmacists to act with their best discretion, when considering prescribing and dispensing these, because, these are, can be appropriate treatments for people, but we're in a time of shortage. So they discourage inappropriate prescribing, hoarding. They don't necessarily agree with prophylaxis or treatment with COVID-19. Which may limit the access to other people who may need them. In Utah, this is, I believe, the shortest duration supply limitation, which is a 7-day amount. Same with a lot of other states. They require written diagnosis. But in Utah, they also indicate language that says confirmed by a positive test. And remember, often that's a term of art. And confirmed by positive test usually means confirmed by the CDC. So if that's the case, that is a very restrictive level. And then, of course, there are some protocols that call for more days than 7. So it becomes more of a logistical, practical nightmare within Utah. And then we're looking at Vermont here. Not anything really different. What they do say is we should only prescribe these drugs for individuals with diagnosed conditions and not for prevention. So they do outright say we don't really agree with the whole prevention approach. One thing to note is that they stated that, hey, Vermonters, we just want to remind you that most people who get COVID-19, you can manage that and there's your symptoms at home with rest, drinking fluids, and taking fever-reducing medications. Talk to your health provider about taking any substance alleged to prevent COVID-19. So don't, take fish tank cleaner. One thing to note about this reminder for Vermonters is that what we saw and what Dr. Bond saw with his patients was that very often they were so sick that they really could not take care of themselves. And so if they did not have caregivers around that were providing them food, helping them to the bathroom, watching them to make sure that they that they were okay and need to be taken to the emergency room and so forth. It wasn't as easy as staying home and getting rest and hydration. So just be mindful of that particular thing. The state of Washington is, the concerns here were pretty much the same. They were concerned about whether or not the prescriptions and the release of the prescriptions, dispensing them, were for legitimate medical purposes. And again, they were also concerned about stockpiling. So what they say in Washington is, we discourage inappropriate prescribing of this medication for prophylaxis, for prevention, which may restrict access for patients that really need appropriate therapy, such as those patients in our state with lupus, rheumatoid arthritis, and malaria diagnosis. So it's a simple, short statement. But if you recall from a lot of the podcasts, Dr. Bond received a lot of pushback from the people within the state of Washington in terms of the pharmacists to fill the prescriptions. And when we actually asked for what legal authority you're using in order to restrict that or require a proof positive test or otherwise, there really wasn't anything. So this is, as far as I know, the only thing that has been issued in Washington, which is merely a guidance or an advice with no force and effect of law. Some notes to consider here is they say we want providers and pharmacists to act with their best discretion to patients to get treatment in times of shortage, so perfectly reasonable. And a reminder that Washington law requires dispensing based on legitimate medical purposes. And, that's just a recitation or statement of what the existing law is. There's no difference there. The state of Wyoming, they state the same purposes, legitimate medical purpose, and to prevent shortages. And again, they reiterate responsibility for both prescribers and pharmacists to ensure legitimate medical purpose. But they specifically call out the pharmacist to consider whether or not the diagnosis is consistent with the evidence, if it's a new prescription for the patient, and then also, depending upon the need for the prescription or what the diagnosis is, consider limiting it to 14 days, which is more than reasonable. And last but not least, we've got South Carolina. And I apologize, South Carolina, for taking you out of alphabetical order. The thing about South Carolina is that they were looking at same concerns, but they worded them all. They were looking at doctor causing shortages. Hospitals were concerned about the availability of these drugs. So if you saw part 1, they were the ones that actually had access to these drugs and continue to have access to the drugs. Also, South Carolina was concerned or took the position that the use of these particular drugs for COVID-19 should be limited to people with an actual diagnosis who were preferably in the inpatient setting. Preferably, not only. So within the advice that they issued, they said that, hey, doctors should not prescribe to self or family without a bona fide emergency. So this was the only state that provided for doctors to prescribe to self and family under an emergency situation if it is relating to COVID-19 treatment. So this is unlike any other state in the union. They're the only ones who actually brought this up. They also state that doctors should consider the effect on the supply chain. If you're going to be prescribing this prophylactically or preventatively, they say they're not saying you can't do it, but that you should be mindful of the impact on other people. They say that the prescription should include the diagnosis, like other states say, and that pharmacists should be using their professional judgment and balancing interests and whether or not to fill. So even if a doctor does prescribe it for prophylaxis and so forth, it doesn't mean that the pharmacist won't do it within their discretion. So there you have it, an analysis of all 50 states. So determine which one you're in, what category you're in for your state. And what the point of all of this was for you to know the facts. From between part 1 and part 2, you'll know whether or not there really is a shortage and if there's more drugs coming. Okay, so if people are using that as a justification for preventing the dispensing of these drugs or refusing to write the prescription, you have the facts now as to whether or not there is a shortage and if the drugs are coming. Also, it raises the question of, can doctors in your state prescribe these drugs for your circumstance if you have COVID-19? So now that you know what the particular situation is in your state, you can determine if the doctors who are refusing to do so are doing so because they just don't want to or because they can't. Also, with regards to pharmacists in your state, if they're refusing to dispense, that's another question. Are they refusing to do so, or is it that they can't? If there's nothing restricting them legally from doing so, then the question becomes will. I mean, it's will they do so within their discretion? And that's a very important distinction to know, particularly if you want to advocate for your rights and the rights of your loved ones. So there you have it. That's part 2, and a summary of the legal restrictions in the country, in each state, regarding to access to hydroxychloroquine and chloroquine. Thank you very much for your time.
Please help support the show by rating and reviewing in Apple Podcasts. You can also subscribe to our Waitlist for Life YouTube channel. That's Waitlist, the number 4, Life, on YouTube. Thank you for listening to Doc Talk with Dr. Bond.